Thank you, Dr. Rathi. And at the onset, I'd like to thank Dr. Ravla for giving me this opportunity to speak to this august audience. So I'll be talking about a very interesting topic, that is white coat hypertension. So the obvious reasons will come to your mind, that whether it is overdiagnosed because we are all busy practitioners, or it is undertreated. So what is the current consensus on dealing with white coat hypertension? Should it be treated? So there are a lot of controversies and lot of problems as regards to how we should approach this. Uh, uh, so first we have to understand how do we define this thing. So WCH is very simple to think: elevated clinical blood pressure with normal ambulatory or home blood pressure. So that is the easiest definition, that in a hospital setting you have raised blood pressures, but when the patient is seeing on his own in the home, or we are performing an ambulatory blood pressure monitoring, the blood pressures are normal. Also known as white coat syndrome or isolated clinic hypertension. So these are the other nomenclatures for the same entity. Then there is a confusing term, that is the white coat effect. So how do we differentiate between WCH and white coat effect? So the European Society of Hypertension reserves the term WCH for untreated individuals only. So the difference is only this: if you say white coat effect, this could be with treated and untreated patients. So a patient who is already on medications, but he is coming to the hospital, his BP rises, and when he is seeing at home, so he will be called as a white coat effect, because he is already getting a treatment for, he is already getting antihypertensive medications. But if he is without hypertension, without any antihypertensives, then we will label him as white coat hypertension. So that is a basic difference between these two entities. So there are a lot of variabilities, and these variabilities emerge from the levels at which we define this thing. So the European Society of Hypertension says that a clinical BP of more than 140 by 90 millimeter of mercury and mean 24-hour BP of less than 130 by 80 millimeter of mercury. So this is there. The American College of Cardiology, American Heart Association says that clinical BP of more than 130 by 80, they are more stringent, and daytime ambulatory or home blood pressure of less than 130 by 80 millimeter of mercury. And the National Institute of Health and Care Excellence, that is the NICE from the UK, they say clinical BP of more than or equal to 140 by 90 millimeter of mercury, and daytime ambulatory or average BP, home BP of less than 135 by 85 millimeter of mercury. So you see there are a lot of variabilities, but more or less if you understand that they are getting to a consensus of more than 140 by 90. So that is something to be understood. And as regards to the home BP or the ambulatory, the consensus is around 130 by 80 millimeter of mercury. So this basically this definition variability, that what that leads to? That leads to an area of lot of, so there is a lot of gray area. So how do we define it? How do we label it? What could be the conditions which could be causing to a rise in blood pressure in a clinical setting? So all these things, there are a lot of gray areas because we do not have a lot of studies as regards to this. Then coming to how common is white coat hypertension. So this is a meta-analysis, and this meta-analysis showed that it is around 13%. But if you see in our settings, if you see, so we are all over-diagnosing hypertension because we are all busy practitioners, and I will be telling you very simple things which can cause an increase in blood pressure in the clinical settings. So those things I'll be telling you, but it may vary from 13, and some studies have shown that it is to the tune of around 55%. So you can understand that how much load, financial load or psychological load we are putting on our patients just because of the overdiagnosis of hypertension. Then etiology could be physiological responses, including immediate increases in BP and heart rate, accompanied by changes in sympathetic nerve activity. So the Hari-Varie-Curry syndrome, and this response is likened to a defense reaction to emotional stresses. So a hospital setting, that smell of the spirit, that also could lead to these things. So this is a very interesting slide. The research has shown that the appearance of a physician is accompanied by an immediate and sustained increase in patient's BP and heart rate peaking within 2 to 4 minutes. And what could be the other way around? So a nurse's visit has been found to promote a significantly attenuated response compared to a doctor visit, provided she is good looking. And even the simple act of placing a cuff around a patient's arm without inflation can cause a peak in blood pressure. So that thing that the patient is being put to some examination, that may lead to issues. So what are the problems associated with overdiagnosis? Ambulatory, so due to varying measurements, patient can be mistakenly diagnosed as hypertensive. Ambulatory blood pressure monitoring is the gold standard to distinguish between this, and without proper out of office monitoring, initial elevated clinical findings can lead to an incorrect diagnosis and rather an over diagnosis of hypertension. So then I would be telling you about some of the problems which could be associated. So a simple sitting or supine position, the diastolic blood pressure in sitting is higher than when measured in supine position by 5 millimeter of mercury. Systolic blood pressure is 8 millimeter higher in supine than in upright position. So these are basic things that we have to understand what we are doing. Without a proper support, this is the usual sitting. The patient is sitting on a table. Sitting without back support, that leads to a raised systolic blood pressure of around 2 to 8 millimeter of mercury. So this is a common finding in our centers. We don't have these type of centers where this is supported. Talking or hand gestures. Busy OPD, the patient, the nurse is also taking the history and at the same time talking. So that could lead to a rise of systolic blood pressure of around 7 millimeter of mercury. Then this is also very common. The sleeve should not be rolled over up such that it has a tourniquet effect. So double tourniquet can be there. One we are putting this and one is the clothing that is using. And cuff over clothing rises the systolic blood pressure by 5 to 50 millimeter of mercury. Very, very common, especially in Muslim patients. This is very common that they are not asking. So there should be a separate room for there where you, in a silent atmosphere, you can look for this thing. Then a simple deflation rate of more than 2 millimeter per second can lead to a significant underestimation of systolic and overestimation of diastolic blood pressure. Then taking tea, coffee, smoking. This is just to take you around what are the problems which could lead to these issues. Then accuracy of the BP instruments. So what instrument you are using? The patient still emphasizes on a mercury one, and mercury is absolutely banned because it is injurious. So oscillometric method is the best, and even those are to be validated. So there are societies which validate these instruments, and these validated devices should only be used. The British Hypertension Society is one of the bodies which is validating these things. So what we can see that this is something like this. So these are the validations, and if they are validated, then only they should be used. Then measurement conditions: 5 minutes of rest, 30 minutes without smoking, caffeine or eating a meal, no excess alcohol, seated, back supported and arms supported on table, desk, box, legs uncrossed and both feet on the ground, and the bladder should be empty. So all these prerequisites are there. So this is not to be a hurried thing. It is a very important thing because it has implications on the patient's well-being and the financial constraints also. The cuff sizes, again, that is also very important. The accurate cuff size should be there for the individual who is sitting in front of us. Then you just take one reading and you say that yes, the patient is hypertensive. So take 2 or more readings, use the average of second and third. So you can discard the first one and take the average of second and third reading. And this has to be done at multiple office visits, 2-3 office visits or more than that, to ascertain whether it is fictitious or it is actually a diagnosis of hypertension. Then this is where I have enumerated, just for the sake, what all things can lead to problems as regards to the variability of blood pressure. It's an exhaustive list, so you can just see and you can take a picture of this. Then these are the problems which I told you with the pictorials. So this is what can happen if you are having these problems. A full bladder can lead to a 15 millimeter increase in blood pressure, systolic blood pressure. So all these things are to be taken. So this is just how you should be sitting and what should be the exact way of recording a blood pressure, how the patient should be sitting when he has to be recorded for blood pressure. Then this is what is given by our own Indian Society of Hypertension. Very easy, wait for 5 minutes. So this is the 5 minutes. Preferably measure BP in both the arms at the first go and take at least 3 readings averaging the last 2. So this is what is given by our own Indian Society of Hypertension. Then consequences of misdiagnosis or unnecessary medication. So what could be the things which could lead to this? So we will have an inappropriate prescription and overuse of antihypertensive medications. This could result in patient being penalized for employment and insurance ratings. Unnecessary lifelong carries potential side effects that could be debilitating. From an economic standpoint, failing to identify WCH results in large expenditure or unnecessary drugs, costing health economics billions. So the other question is whether WSH is clinically innocent condition or is it associated with a greater cardiovascular risk. So it is linked to cardiovascular risk factors, including the development of sustained hypertension and the presence of target organ damage. So we have studies which have shown that it actually could be something like a pre-hypertensive stroke. So it could lead to sustained hypertension over a period of time. So WH is also associated with metabolic alterations. So can we label WSH as a pre-hypertensive state? The opinion is divided, but individuals with WSH has an increased risk of developing sustained hypertension. So we have studies to say that the patients with WSH are 2.5 to almost 3 times more likely to progress to sustained hypertension compared to normotensive over long-term follow-up periods. So don't overdiagnose, and at the same time don't just exclude this thing. So this could be a portent for something which is going to happen in the future, or it could lead to future complications. So how do now the question arises that yes, we have understood this thing. So the problem is we have to understand that whether the WSH is associated with target organ damage or not. The TOD is most important. So which is an important predictor of cardiovascular risk. So we have to understand, is it associated with left ventricular hypertrophy, carotid atherosclerosis? So if it is there, then we have to be more careful and we have to be more proactive in treating these patients. So the debate on cardiovascular outcomes. So this is inconclusive. The meta-analysis on untreated WCH and CV outcomes have yielded inconclusive and sometimes conflicting results. So we do not have a clear answer that whether these are to be treated or not. Some studies indicate an increased risk of CV events and mortality in untreated WCH. However, other analysis found no significant difference in CV risk between WCH and normotension. So the jury is still decided what we should do. So the factors influencing CV risk in WCH. So the cardiovascular risk in WCH can be influenced by associated cardiometabolic risk factors. So if you are seeing a patient who is having a true white coat hypertension, you have to understand that you have to explore for the other cardiometabolic risk factors. So that is important, and that is the point which is to understood. Age is important and persistent of elevated office blood pressures. So these are the prognostic points which will yield that we have to be more proactive in treating these patients. The caution of treatment of WCH, the scarcity of large prospective randomized controlled trials. Existing evidence primarily comes from subgroup analysis, and some studies suggest treatment benefits only those with sustained hypertension. So we should be focusing more on lifestyle factors in these patients and a more frequent follow-up, because these patients have a potential to have other cardiometabolic risk factors or the development of sustained hypertension. Then European guidelines say low CV risk or elevated CV risk. So they have decided, so if there is a low CV risk, the patients with WCH and no additional CV risk should be managed with lifestyle changes and close follow-up due to increased risk of developing sustained hypertension. And in elevated CV risk, they have to be treated properly. So this is the paradox of WCH severity and risk. WCH presents a paradox. Its severity, the difference between office and out of office BP, does not necessarily predict CV risk. So we have to judge, and your clinical acumen, I think, is of paramount importance. Negative impacts, we have already told about the financial impact, absenteeism, and the labeling that you already have a problem. So that is the biggest problem, because this particular thing is associated with this thing. So these are important things. Effective communication, physician training, and patient training could yield better results and reduce the overdiagnosis of white coat hypertension. There are key research gaps I've already pointed out to you in the previous slides. So concluding my talk, WCH is a common condition and which potentially overdiagnosed due to clinical measurement variability and lack of reproducibility. Accurate diagnosis using out-of-office BP monitoring is crucial. So home BP monitoring or ambulatory blood pressure monitoring could be the way out, and continued research is essential to definitely clarify WCH's prognostic significance and to establish evidence-based treatment strategies. So thank you very much for patient hearing, and I would be very happy to answer any questions.